welcome. We've got Dr. Ffion Davies presenting this evening. I'll give her an introduction a little bit later. First, could we say thanks to our sponsors, who are Slater and Gordon. They work in many major trauma centres around the UK. They're a firm of solicitors, but very interested in getting early rehabilitation to patients, and that's an interesting thing because, of course, early rehabilitation is in everybody's best interest to decrease the impact of injury, not less our patients. The usual disclaimer for this website that we talk about stuff, but actually, even if we say things, you need to work within your own protocols of your employing organization. So don't do stuff just because we say you should do stuff. You need to either check it out with your employer or follow their protocols. Presenter can't hear you, so if you need to chat, put things in the chat. If you have questions, put them in the Q&A. I'll be looking at the questions. We'll have about 15 minutes in the end with Ffion when we can go through those questions. Certificates of attendance to all members that attend the webinar for free, and also free access to the entire recording for members. If you're not a member, why aren't you a member? You should become a trauma care member. You should support us in trying to bring this sort of free education and these great speakers that we've been lining up for you through the year. So either become a member or you can pay a one-off for a CPD certificate at the end of the presentation. So, speaker this evening is Dr. Ffion Davies. Ffion was the first duly qualified consultant in both paediatric and adult, in both paediatrics and adult emergency medicine. She was instrumental in developing PEM, Paediatric Emergency Medicine, through her work chairing the intercollegiate committee between the Royal College of Emergency Medicine and the Royal College of Paediatrics in Child Health. Fion's also a past president of the International Federation for Emergency Medicine, the worldwide body that brings all of the different national emergency medicine societies together. She's a member of the World Health Organization Acute Care Action Network. You may well have seen her video site called Spotting the Sick Child, that hopefully we will get Ffion back in the future to talk about spotting the sick child. But you'll probably also know her book on minor injury in children, which is the standard text that's used in emergency and acute care up and down the country. So Ffion's going to talk to us this evening about minor injury in children, and perhaps also help us with looking at when a minor injury perhaps isn't quite such a minor injury. Over to you, Ffion.
Thank you, Tim. Can you hear me okay? Great. It's lovely to be with you all this evening, afternoon, morning, wherever you are. We see people from Qatar, people from Malaysia. It's fantastic. So yes, my name is Ffion Davies. We're going to have a little canter through some minor injuries here. So why would you want to know about minor injuries? Well, for starters, as soon as you're a qualified health professional, children injure themselves left, right, and centre, and your friends and your family and your neighbours suddenly expect you to be an expert. So that's one reason for listening. The other is that it is really a lot of fun. We have so many broken lives in our patients, don't we? And we can only fix part of it and can only listen sometimes and be empathetic. But actually, for kids with minor injuries, it's great. You can fix things and they go out the door smiling and waving, and it's really actually very satisfying. So as Tim said, I'm trained in both adults and paediatric emergency care. The book is out. It has that edition is the third edition, has been out since 2019, something like that. And the fourth edition is with the publishers at the moment, will be out by the end of the year. Shameless publicity there, don't worry, I'm not making a mint on it, very little actually. Okay, we're going to go at quite a pace because there's an awful lot to minor injuries, and what you probably want to know, where I've said pearls and pitfalls, is what is perhaps not a minor injury. So there's quite a lot to cover. If I'm going too fast, please put things in the chat. Tim will either interrupt or he'll store them up, and we can answer your questions. So, what are we going to talk about this evening? We're going to talk about the fact that common things are common. So, we're going to have a quick refresher of what is common. When is a minor injury a major injury? When is a minor injury not even an injury at all? It's masquerading. And the thing that we all have to deal with, sadly, is how do I spot child abuse? So let's talk about some horses, common things, before we talk about zebras, which are the less common things. So as a guide, common things are common, and on the left-hand side you see the sort of more familiar fractures that we see in children. On the right-hand side you'll see things which are very unlikely in children, which is the spine fractures, rib fractures, pelvis fractures. They happen, but usually in quite dramatic circumstances, not just falling over. So let's talk about some common scenarios then. So here's an 8-month-old infant who's fallen from a shopping trolley to the floor. So when we hear that history, we think, is an 8-month-old capable of climbing out up and over? Yes, they are. Is it neglect? Did mum just turn her back? Or was she neglectful? Well, if mum was the other side of the supermarket, that's one thing. If she literally was just getting something off the shelf, then these things happen. So you're thinking that through, and then you're thinking, well, it's only fallen from a shopping trolley, it's not that high. So how high is a significant fall? And one of the things that everyone always seems to search for is a boggy hematoma. So what are we talking about and why? So any fall from the child's head height and above can cause significant injury. So that's where we start to say that's a significant height. And often they'll only have a linear parietal skull fracture. They won't be at all harmed by it, and it'll be gone in 3 or 4 weeks' time. They heal so quickly. But they may have more, they may have a subdural. And so generally, once it's above the child's head height, we'll have a lower threshold for a CT, but we're still going to see what the child looks like rather than necessarily the physical findings. But if you do find one of those hematomas where you put your finger in and it just feels like your finger goes really deep into this squashy thing, then that's what we mean by a boggy hematoma. And those ones, particularly if they're more than 5 centimeters wide, are significantly associated with positive findings on the head CT. That is not the same thing as the egg on the forehead, which is a really common thing, and it's often the size of an egg which gets the parents to have brought the child in the first place. But actually, big eggs on the forehead are quite common. Other common things, fractured clavicles, very common. So this child is 3 years old, fell over yesterday evening, complaining of shoulder pain, not using their arm properly. But often if it's as subtle as this one, they'll move their arm really quite well. So although we're taught all the time, if there's a delay in presentation, you need to be thinking about neglect or an abusive injury. Actually, for these ones, it's very common. You often won't even notice until you get the child's arm out to 90 degrees, and it's only as you push it that little bit further they start to whimper and pull away from you. That is just on the one side of the cortex. You can see that fracture. It's unicorticate and therefore it's a green stick fracture. We'll show you another one of those in a bit. So it's subtle and it's not neglect, it's not NAI, it's just common to come a day or two later. Okay, what do you think this one is? So there's an 18-month-old girl playing with her older cousins. Mum hears some sudden crying in the other room, takes 10 minutes to console her. Nobody will really say what went on, but since that time, she's not using her left arm. Other than that, she seems fairly happy. Yeah, people onto it already, thank you. Pulled elbows, very common in the 1 to 3 year old age bracket. So it's a tugging or swinging injury, it's axial pulling, which we do all the time with children because we play. And the arm is being held usually quite limp by the side, partially flexed. You'll see just a little bit of flexion at the elbow, and the child's often carrying on as if nothing's happened, other than they don't want to use that arm. We don't normally x-ray them if we've got a classic history in a classic age group, but under 1, over 3, or in this case, when nobody really could tell you what had happened, then we will tend to x-ray them first. Then once we're confident of the diagnosis, we go on to reduce this. It is subluxed, absolutely right there, Neil, not actually dislocated. Dislocated elbow is the wrong phrase for this. So we need to get it back through its annular ligament. So we're going to keep the elbow a bit flexed. We're going to have one hand doing twisting and the other hand's going to be poised over the head of the radius, just beyond the elbow there, just to see if we feel a click. We're going to hypersunate it, and if we don't hear, sorry, hyperpronate it. If we don't hear and feel a click, we're going to try the opposite and just spin it around the other way, and then back off, leave the child alone to play for 10 minutes and see what happens, because by this time they're hating you and they're crying. You sometimes do need a second attempt to get the child better. Sometimes, if you're pretty confident what it is and the second attempt doesn't work, we send them home in a collar and cuff and they never seem to come back. It just seems to put itself back. If a child is prone to this, they'll be prone to having it recurrently. Certainly, GPs and social workers have contacted me in the past and so this child's had three pulled elbows. What's going on? It's just that child's a flexible child and it's just the way it is. So that's what we're trying to do there. Keep it a little bit flexed, keep your thumb over the head of the radius and give it a good old twist around all the way until you feel it won't go any further. And if you didn't feel the click, turn it back the other way externally. So let's talk about a few more common things. So the distal radius, the wrist, is a very common place for children to have fractures, and that's children of all ages. If they're nice, soft, young bones, that's usually under the age of 10, you see this pattern where there's just a bulge in the bone. So you can imagine clinically that is pretty subtle. So my rule of thumb is if any child points to the distal radius specifically when you say where does it hurt, they're pretty much getting themselves an x-ray because this is what you're going to find. They don't necessarily need plaster. We put them in splints and they just get better, the remodel. What you might find is a green stick fracture where one part of the cortex is broken and the other side isn't. And these can be anything from very, very subtle to the one you see in orange there, which is obviously pretty obvious. Same as elbows, they can be extremely subtle, or they can be what you see there in the green, which is a off-ended displaced supracondylar fracture. Now, this is where a minor injury becomes a major injury because crossing there, you've got the brachial artery, brachial nerve, and you've got a lot of potential there for ischemia if there's any movement and shearing of that vessel. So that one is for being wrapped up and kept as still as possible till you get to expert help who'll be able to just give it a little bit of reduction, then it's off to the operating theatre. Children also get other kinds of fractures. You see the midshaft radius and ulnar there, which is just a little bit kinked. That again, very, very subtle. So generally we have a pretty low threshold for plain x-rays in children because they'll have these subtle kinds of injuries, mainly because their bones are soft. Other injuries, which we see very frequently and coming with a lot of drama, seems to be any child who's trapped their finger in a door, particularly fire doors, that sort of thing. And actually, children have amazing potential to just grow a finger back to normal. So, you know, we joke with them about worms and starfish and things that grow themselves back. You hardly ever need a surgeon for these injuries. And certainly, I've worked on helicopter shifts where we've got called out for one of these. There's no need for that degree of escalation, just a lot of calming. The other thing that seems to get everybody on the ceiling is burns and scalds, high drama situations, but actually there are very few burns and scalds really that are going to cause any long-term harm. And we all know what they look like when the blisters come up. They look nasty, but they all heal. So just simple analgesia. If you're dealing with this pre-hospital, be generous with your analgesia. We all know what a burn feels like. It is sore. So paracetamol and ibuprofen, or if you can in your protocols, then intranasal fentanyl or the wonderful Penthrox. That would be off-label use, by the way, for under 18s. But now with enough research evidence in the UK to show that Penthrox is as useful in children as it is in adults, a lot of pre-hospital and hospital services are now using it off-label. So if you've got it available and you're allowed to use it in children, please do. Just another one to dispel a myth. Most vulval injuries are what you're told they are. So everybody gets a bit nervy about them. But we did a study, I think we did a year's worth of children, and actually it was as per story. We didn't find anything that was hidden sexual abuse. We found a couple of self-harms, but no actual sexual abuse. So if it's the typical one would be particularly a girl who falls astride the bicycle bar or astride the bath, slips as she gets out, that kind of thing. But there's no need to get quite as nervy about them as we do. Anyone want to have a go at this one? 2-year-old girl who stumbled when out on a walk. cry straight away. She's limping along, crying. Have a look at her lower leg and you can't really see anything. It's not swollen. You press on it. The child doesn't seem to um, to resist you. So yeah, we got toddler's fracture coming in there. That's exactly what it is. Toddler's fracture is a spiral fracture of the tibia. We're going to talk about a spiral fracture of the humerus in a bit, and this is an entirely different thing. This is nearly always just accidental. Children can stand up and twist suddenly. You know what toddlers are like when they see something and they're interested, they'll just stand up and twist at the same time. Even that can do it. But particularly if they fall, you'll often hear the history of they twisted awkwardly or they landed awkwardly on their leg. That will be a toddler's fracture. You won't really find any tenderness on direct palpation over that fracture site, but if you try and dorsiflex that foot and give it a little bit of a twist one way or the other, that's when the child will wince and they'll pull away from you and they'll start crying. And then you know you're causing a bit of shearing and there's a fracture in there. Okay, let's just give you a zebra or two. Anyone seen this one? 9-year-old falls backwards, complains they cannot see. Any, if you have seen one, put it in the chat and tell me what age your patient was. No, no one coming in. Do you believe them? They've got their eyes open but says they can't see. Actually, it is a form of concussion. It's falling onto the occiput, so it's falling onto the back, and it does cause temporary blindness because of the concussion of the lobe. If you listen closely enough, you will once or twice in your career hear that story. And I feel sorry for the kids that a lot of the time they're not believed. If they are believed, everyone gets quite anxious about it, but actually it's harmless. It'll last usually less than half an hour. I think the longest I've seen is an hour or so. I've given this talked about this injury on several talks on minor injuries, and the oldest I've heard of is a 26-year-old who was a motorcyclist. So it seems to be a young person's problem, but it does happen. So yeah, worth knowing about, just so you give the poor child some credit. Does it mean much? No, not in itself. It is a form of concussion of that lobe, but if the child is otherwise fine, it's the same CT rules as you would use for any other head injury. Let's talk about three more things that aren't strictly injury, but I thought I'd throw them in because we don't get a lot of teaching, do we, about minor injuries? And the interesting thing is that unless you do pediatric emergency medicine, obviously orthopedic doctors are quite skilled, but they're not skilled in some of these areas. And the pediatricians, I don't know if anyone listening is a pediatrician tonight, but they get very, very little training in normal injuries, which I always find a bit strange because they're trying to make a judgment call very often on what is non-accidental injury when they haven't really got a lot of training in accidental injury. So let's cover a few more things that come through the doors. Um, this one is a hair tourniquet syndrome. I don't know how many of you have ever seen this. Very distinctive when you see it. It's not difficult to diagnose. Not that common, but it'll tend to be babies. It'll tend to be children who've got mothers with hair a bit like mine, long, that falls out easily, and it will be twisted around the bottom of that digit. Probably 2 or 3 times you'll see it coiled around. And in the old days, we used to go digging around with suture removers and various things, or send them to the operating theatre where the plastic surgeons have got their microscope goggles. But oh, interesting. Yeah. So 10% are the finger, 90% toes. I've not seen one on the penis, but I have seen case reports on that. And we've got Fiona coming in on the chat, labia minora hair tourniquet. So yes, they can wrap themselves around anywhere. It's thought that something just happens by chance when the mother's usually changing the nappy and there is hair falling down on the baby. Yes, so Sandy's absolutely right. We don't need to dig around these any longer. We've got hair removal cream. So it's just down to the pound shop and get yourself some of this in. Um, it can sometimes not go all the way through, but most of the time it will. Much better actually than the digging around that we used to do. You need probably half an hour after application to be sure that this digit's recovering. You want to see some recovery in the digit before you let them go home. Okay, so that's just interesting things you may not have heard of. Another very common thing, this is definitely a horse, not a zebra, is nasal foreign bodies. Children love to stick things up their noses. Sometimes they'll tell you, sometimes they don't. Sometimes they tell you today, sometimes they'll tell you in 2 weeks' time. So beware foreign bodies. Again, we used to pin the child down. We'd have forceps. It would be screaming and kicking, and you'd be risking this airway, thinking, is this going to go the wrong way and go up the airway? But somebody somewhere about 20 years ago described the kissing technique. And what the parent does is obscure the nostril that is normal and then seals their mouth around the child's mouth and a really short, sharp puff, a real in order to expel it. It may take 2 or 3 goes as it travels down the nose before it actually comes out. If you've seen, uh, actually, no, it's not on Spotting the Sick Child. It was on the minor injury video we did, where the parents blew it out and it literally, this pea flew across the other side of the room. I found some parents have come in and said they've tried it at home, they've known about it because they read it on the internet on what to do, but they weren't able to do it, so they brought the child in. So it's obviously the word is out there. If you can't get the parent to understand the technique and create a really good seal around the child's mouth and be a real short, sharp puff, you can use bag valve mask to do the same thing. Okay, what's this one? This is another horse, not a zebra. Anybody? Yeah, so it's sort of, yeah, breath holding. Anoxic reflex seizure is like the extreme end of the spectrum of breath holding. So it used to be thought that the child was either having a tantrum or had hurt themselves and were crying and exaggerating this deliberately. But actually, it's not. It's involuntary. It's the vagus nerve that has causes this profound response. And the first thing they'll do is just stop in their tracks. Usually the key to this is that they'll show recognition on their face that they're in pain and they've just had a shock from falling over, banging their head, or trapping their finger in a door, whatever it is. They'll show recognition of being hurt, and they might even start to cry, and that's when they suddenly stop breathing. This can then last 2, 3, even 4 minutes. Some children do it quite a lot, and the parents will get used to it. It's not easy first time around when you see it, but some parents get used to it and they grow out of it usually by about 4 years old. But it can continue through to teenage years. If you ask in the history, you might detect slightly milder episodes when they've fallen over before or when they've had vaccinations, but the ones that tend to call an ambulance or arrive at the ED tend to be the more dramatic ones. And the reflex anoxic seizure is when the apnea goes on long enough that they go really proper blue, and sometimes they'll jerk a few times. You can even get asystole with it, and there are some amazing videos that are out there, 30 seconds of asystole, and then bam, you're back into sinus rhythm. So it is dramatic, but it is absolutely harmless. It really is. If you know what it is and it's absolutely typical, it is harmless. So it doesn't class as loss of consciousness for a head injury that therefore requires a CT scan. You've got to make sure that you identify these as different from loss of consciousness in primary head injury sense of the word. Yep, so lots of you got that one. Oh, and Tim got that one. Well done, Tim. Okay, so we've talked about common things. We've talked about things that might catch you out a little bit, but let's look at some proper red flags here. How are we doing for time? We're doing all right. So when is a minor injury a major injury? We've talked about some of these fractures where you're jeopardizing the circulation or the nerve supply. And then some injuries may present as a minor injury, like this one on the right, which is a spiral fracture of the femur, but actually are something a lot more serious. So we are going to talk about child abuse, because that's what worries all of us. We don't want to miss neglect and we don't want to miss child abuse. Again, not quite an injury, but I do want you to know this. If a child swallows a button battery, particularly the larger ones, 20, 25 millimeters, can it kill a child within 2 hours of ingestion? Somebody's just going back on the breath holding, what to do. Nobody's really sure. People say turn the child over, turn it a little bit upside down, blow in their face. Whether that actually works or whether the child was going to come out of it anyway, I'm not sure. What you might want to do for parents that might have their child do it recurrently is get them to go onto YouTube because there's some really good videos. If you want to see a breath holding attack, YouTube it and you'll find them. Right, so what's the answer to this one? And the answer is true, 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 all the way down the chat. Absolutely. If it goes the wrong place, particularly if it gets stuck at cricopharyngeus, which is just at your the top of your sternal notch there, then you're in big trouble. It is really close to the aorta, it is really close to the esophagus, and that's a piece of meat you can see there. That is 2 hours of a button battery on a piece of ham. So if you can do that, it can cause a lot of trouble. And there were, particularly before there was so much awareness publicly, some pretty nasty cases of things eroding through noses right through to the maxilla, things eroding through the throat, through the trachea, and the worst one of all, which is an esophageal aortic fistula, which has got a very high mortality unless you've got a cardiothoracic surgeon standing next to you. I wanted to just talk about when a minor injury is not a major injury, because some of you will recognize this one, which comes across as a major injury and it's not. So I've taken the liberty of calling it teenage dramas. Have you seen this? It'll usually, I'm not being sexist, usually be a girl, probably 70% of cases are female. They'll usually be 13 to 15, and often the story is that they were injured by someone else. And what's happened next is that they'll hold that limb absolutely rigidly and get themselves super stressed about it. And what you're presented with is a limb that's cold, pale. They won't move it. They're screaming when anybody goes anywhere near it. Every movement is painful. And it's just worth knowing that this happens because it's not as dramatic as it looks. It's an autonomic thing and it's due to getting so upset about it and holding your arm in an abnormal posture and not moving it. So over an hour or two, it will go that pale and it'll present with a lot of pain. You can often not have even touched the child before they're starting to say how much it hurts. And what you've got to get the child to understand and the parents to understand is that this is because they're holding it so stiffly and because they're feeling so much pain, they're getting this exaggerated response. When you try and get them on board with that, you try and encourage the child in front of you just to move slightly, just a little bit, and just do this for me, and just do that for me. Really firm but gentle coaching till you get them to demonstrate it will move. And then you need to get the parents on board with following that through because you won't get them jumping around normally in the emergency department. But get that faith that this will get better and get them to do their own staged physiotherapy. By Tuesday, I want you to move it that far. By Wednesday, to see if you can move it this far, and give them a 2 week plan. But say to the parents, if they're not right at the end of 2 weeks, they need some professional help because they do, because these can really go on to be over investigated and cause a lot of long-term problems if you don't get out of this vicious circle. I've lost the plot on the chat where Honey came in. We can come back to that later. The other time when a minor injury wasn't even an injury is remember how often children do injure themselves. So you'll often hear limb pain presented as, well, he must have hurt himself when X happened in the last few days. Seemed all right at the time, but today he started limping. Or we think he must have done X, Y, Z because it's natural. We all want to explain why this child seems to have limb pain. And we'll often find something in the last 3 days that could have caused it, but beware of that one. That's a red flag. If we don't really know, we think it's because all sorts of things hide under that one. One of the things to be really aware of, it is a zebra, but it's a bad one, is she pauses because she's not got the answer on the slide. Anybody? Fever, not using the arm. Might do an x-ray, even that's normal. Yeah, thank you, Kelly. Got it. So septic arthritis. So under twos don't have a very good immune system. The immune system's still learning, and anything that floats around the bloodstream can spread and lodge, is essentially what happens. So it might be a bit of Staph aureus from a little cut. It'll lodge, it'll go deeper, it'll go around the blood, and it'll find a weak spot, and joints are weak spots. So beware of septic arthritis. It does happen and it absolutely damages a joint within 48 hours, can eat through the joint and cause absolute havoc. It is subtle though. It's really pain and fever the child's going to present with. The limb itself, often in the early stages, does not look that dramatic. So this is one way you just need to have awareness. More things to just be aware of. Limping children are quite common as a presentation. Tend not to call ambulances because it'll be more gradual, but very common presentations to GPs and to the emergency department. The diagnosis often depends on the age group. And as I said before, the history of a trauma is usually a red herring. And the one thing I really want you to remember is that hip pain often presents as knee pain. So here's one, Perthes disease. You don't need to know all the detail here, but just be aware of the fact that children get these things. So with or without the history of trauma, beware the limping child. So this is Perthes disease, which is osteonecrosis of the femoral head. And you'll just see the femoral head down the left is smaller than the one on the right. And that's a sign that its blood supply is affected and it is shrinking. That needs an orthopedic surgeon. This one also needs an orthopedic surgeon. Oh, I've lost my lines. So this is slipped upper femoral epiphysis, a little bit older, goes up to 14 years old. Again, knee pain, thigh pain, and pretty subtle. It's only as you're externally rotating the hip joint, you see the child sort of resist a bit and go, ouch. Um, no, I can't do this because I've lost my lines. If you were the right femoral neck, if you took a line along that neck, you'd find that the head pokes up above that line. If you look on the patient's left femoral head, it doesn't. That's because the whole femoral head has slipped down, and that again needs an orthopedic surgeon. So just beware of limps. The only limp that's innocent really is an irritable hip, and that'll tend to be the 2 to 5 year old. It's harmless. We don't know what causes it. It's just a case of making sure it's not one of the other things, especially septic arthritis. Last 5 to 10 days, um, managed conservatively just with painkillers, but they must come back to hospital if they get a fever. If it's rapidly getting worse, it shouldn't do an irritable hip, or lasting more than 10 days. And I'm just going to give you the long list of things that cause limps just to scare you, just so that you take limps seriously or leg pain seriously. Other things that present as minor injuries when they're not really minor injury that you just need to be aware of is any funny gait or funny posture with a child walking funny. Be very, very careful with those. Back pain, not common in children at all. So think TB, discitis, tumours. Children do get bone tumours, a lot of bone tumours. So I'm going to keep going with a list that goes on and on and on, just so that you're aware of the fact that children get these things and a minor injury may not be a minor injury. Limb pain needs its own workup. And I've seen certainly fractures through bone cysts and cancers where the pain has been extreme. The child's had a relatively minor injury and they've been poo-pooed, particularly if they're an adolescent. Adolescents get a hard time, making a big fuss about nothing, but actually they've come back and got something nasty like a fractured neck of femur right through a horrible cyst or a cancer. So beware of these things. Okay, what do these animal species have in common? So we're going to come off our minor injuries and go into the nasty territory now. Are they? Yes. Oh, they are all mammals. What do they do that's not nice? Yeah, so you've got parents of little ones, and what do some parents of some little ones unfortunately do, including Homo sapiens, is unfortunately do bad things to their children. And that is all over the world. So I gave a presentation on non-accidental injury in Brazil last month, and there'd just been a recent case of severe abuse. So it is unfortunately a worldwide problem. I have to say the systems we've got in this country are extremely good. For all the negatives you might hear in the press, we do have very good systems, and the incidence of abusive injury, and particularly death, in many other countries is way, way higher, whether it's the USA or India or many other places. So we should give ourselves a bit of a pat on the back for the systems we have in place. So what do we think this is? He's been crying all morning, doesn't seem to be using his arm. And that's all you can get out of the family. Or you might sort of say, well, could he have hurt it? Was there anything? Oh, might have done this, might have done that. Yeah, so Richard's got it. So this is a spiral fracture of the humerus. We talked about the spiral fracture of the femur, which can be abusive, but is more often accidental and just through falling in a twisting injury, same as the spiral fracture of the tibia. But when you see it in humerus, that is not good. That nearly always means child abuse. It's a twisting injury, and you can imagine what that fracture feels like. Children feel pain just the same as us. So that child will have been in severe pain as soon as it happened. So whenever you hear a child suddenly cry, most of you would be parents, you will know this, you're immediately searching for why, what happened, what happened. So you're not going to give the story of, oh, I don't know, or he didn't seem to be in pain. There's something going on that's being concealed. And being concealed is why we call it stealth injury. And we're all very aware these days of silver trauma, but that is stealth injury as well. We've all seen the elderly person who falls from standing height, but on CT has got multiple injuries, fractured pelvis, fractured ribs, etc. Well, unfortunately, the physically abused injuries of infants are also stealth injuries very, very often. And you'll often find when you go looking with imaging multiple injuries, and they often are relatively uncomplaining because the injury might be days or weeks old, and you'll find all sorts of things on CT. So this topic used to fascinate me because of course, it's awful to get false positives or false negatives, isn't it? You don't want to accuse anybody who's innocent, and you don't want to miss somebody who has done something to a child. So it's tricky territory. And so we decided to look at the major trauma data from TON as it was then. And we found that 7 to 12% of major trauma, major injuries, this is high ISS scores because it's TARN data, is actually caused by physical abuse. So I thought this was an interesting topic for research. So trawled the database, got lots of information, and the first paper that we published was looking at the demographics, so how much severe injury is due to abuse, what age are these patients, what's the injury pattern, what is going on in the UK. Paper two, we compared the patient journey, so from injury to hospital and then to discharge or death, what happened to these children? Well, here's your age breakdown. Now that's interesting, isn't it? We all think it's the teenagers that go around severely injuring themselves, doing crazy things. But look at the under ones there. And even more interestingly, we'll break that down and look at that closer. Here we now got age in months. And look at that. 1, 2, 3, 4 months old, we're seeing severe injury. Well, these are infants who can't even roll yet. They're just waiting to be placed places by parents or families. And yes, of course, anybody can accidentally drop a baby and they might get a skull fracture and a bleed. But unfortunately, the more common situation is worse than that. Now, when I showed you that graph, you're thinking to yourself, well, that's like all the stories we hear about these terrible, sequential problems with children. And there's one in the news at the moment, isn't there? The adopted child. It doesn't quite match what you read in the news. Well, that's because of media bias. Everyone loves that missed opportunities. The more contact they've had with teachers, GPs, ambulance workers, whoever, social care, the more there is a blame. So you'll tend to see the older child in the media. If you keep your eyes peeled, though, and you're looking for other reports, less headliney, you'll see that actually that age group, 3, 4 months, is what it is. And any child can be abused emotionally, sexually, or physically, but unfortunately, it does correlate to male controlling behaviors that are men often not the biological father of the child, mental health problems, emotional lability, drug and alcohol misuse is the more typical scenario. And when we turned it the other way around and said, for abusive injury, what is the age range? 98% was in 0 to 5 year olds for severe injury, and 76% occurring in infants under the age of 1, like we showed you on the histogram. Median age for those was 3.6 months old. So here's a clue. When we're thinking, well, this one's hard to spot, here's your clue. Just think about your age group. Why, why would a baby of 3.6 months old injure itself badly? There has to be uh, an account for this. It doesn't, they haven't just toddled off somewhere and tripped over. And it can be really, really subtle. So the things that we know that are hallmarks of abusive injury, retinal hemorrhages, subdurals in the brain, little corner fractures of the metaphysis of the long bones, all of those things are actually quite hard to spot. Even the spiral fracture of the femur that we were talking about in chubby thighs can be really hard to spot. If you're interested in typical abusive patterns and what children present to the emergency department, the RCPCH has got some great resources on their child protection evidence. Here's just a list, I'm not going to go through it, of typical abusive injuries, but many of these can be there with a child that doesn't look that unwell. And of course, they can present as a medical illness. You can imagine this child might just be drowsy or vomiting or non-specifically unwell, or they might come with seizures. So it takes a bit of a detective to figure out actually this child's got abusive injuries. They haven't got sepsis or all the other things that children come to us with drowsiness and vomiting. The seriousness of injuries is very high. So the death from head injury for abusive versus accidental head injury is much, much higher. When we looked at the patient journey, we were interested in, do ambulances get called? How long does it take them to get to hospital? How often are they going to end up at a major trauma centre and be greeted by the gold standard consultant-led trauma team, be intubated, get to CT? And the answer is, as you'd expect, they didn't do well. So along the top there is your stages of the patient journey and what we would hope would happen. At the bottom is what actually happened, and all the way through, the accidental injuries fare better than the abusive injuries. 27% of severely injured children with from abusive injury come via ambulance. What do the others do? They're brought in through the front door. So we have to be on high alert for these. With stories like, no history of injury, just she's very sleepy, we can't wake her up, he's just stopped breathing. That'll be an apnea due to the subdural. If you work in the pre-hospital arena, then you need to have that detective in your persona. You need to be asking questions. You need to use your eyes. You need to have a look. You need to follow your gut instinct, and you need to spot when there's something that's not right. So for this particular child, they apparently found her lying unconscious with a swollen and bruised face. And when she was found and the paramedics got to her, she was wet. Investigators later noticed the bath had been spotlessly cleaned, despite the rest of the house being very dirty. This was, this isn't adding up here. Have a think about when you had an injury as a child. If you said to your mum now, 20 years, 30 years later, do you remember that time that I X? She could still tell us what time of day, who you were playing with, what you were wearing, what happened next, and then this happened, and this happened, and then I called your dad, I called an ambulance, I did this, I did that. Blow by blow account, I guarantee you. Accurate recall with full detail. You'll be your mum will be looking at you and then be looking away, playing that video in her head. She can still remember that day to the second. People who lie generally divert their eyes away, are hesitant, evasive, and don't like to provide too much detail. That's because if they're asked that detail again, they need to remember exactly what they said. We need to uncover this. We need to ask questions. We need the facts, but it is very difficult pre-hospitally because often the scene can be really kicking off. What the last thing you want to do is have that baby taken away by alienating the parents, particularly in the emergency department. We start to ask questions. The last thing you want is for them to run out of the door. So we need to disarm the hostility, reduce the defences, and that's when we need the detail. What position was she in when you first saw her? What was the first thing you did? What was the next thing you did? Who called the ambulance? What happened next? We need every little piece of this jigsaw and then record everything in the medical record because the story might change in the next hour, day, week, or month. Right, that was cheery, wasn't it? So we've covered the common things that are common. We've remembered that there are zebras. The biggest clue to child abuse is the age and a vague story. Trust your gut instinct. I didn't want to end on a negative note, so let's remember why we do what we do and remember the fun moments when we work with minor injuries in children and get them better and get them fixed, and everyone goes away happy. So let's end on a happy note. Thank you for your attention, and I'm going to stop screen sharing so we can go to some questions and over to Tim.
Thank you. There was an interesting comment from a couple of people around honey and button battery injuries. I hadn't heard of giving honey very soon after someone's ingested a button battery, but at least two people on the call are saying they keep honey in their emergency department for that. Um, I don't know if anyone's ever done that experiment of taking a button battery and putting two pieces of ham either side. It's a great demonstration of what happens.
There
So,
is some evidence, but I would hate to see anybody messing around with honey when we need to know where this battery is and what it's eroding through. So, um, I would not be doing that. I want an X-ray. I want to know where this thing is.
yeah, so rapid movement through the system, rapid getting in touch with somebody that can fish them.
Yeah, if it's retrievable and it's in the nose and we've got it out, we might want to apply honey, but no, can't answer that thoroughly. Sorry.
That's good. There's a question about leukemia presenting as limb play
Yes.
pain. And how that happens. And I think just wanting to know a little bit more about that, and also wondering if you can flick back to the slide that has leukemia in it as one of the causes of limb pain.
Yes, I can do. So, in most children with leukemia will have blast cells, and these are big cells, and the bone marrow starts to proliferate because it's reacting to the leukemia, and the cells themselves are bigger, so the bone marrow literally gets stretched and causes pain. And actually, bone pain, we know this from intraosseous infusions, is really nasty pain. So, a child might often present with a limp or just being unwilling to walk. And the clue is going to be looking at that child for whether they're pale and asking the parents if there's been any bleeding recently, nosebleeds, gum bleeds, easy bruising, that sort of thing. But that's the pathology of it. Um, David, oh, I'm sorry to hear that, David, but yeah, I hope somebody cottoned on to the limb pain. Do you want me to have a look back on that slide then to show the other causes?
If that's easy to do, perhaps I'll answer a question in the meantime. Can we access the record? Yes, this recording of this is going to be up on the Trauma Care website, so Trauma Care members can access it there, and also on our YouTube channel. Are there any short courses on pediatric minor injury that we can access? Um, is another question there. Obviously, the best form of education is to read Fion's book. But Ffion, do you know any short courses?
No, they're not actually. I think there's a real
Hmm.
gap in the market there. I do a lecture similar to this on the first 4 hours pediatric emergency medicine conference, which is now a 3-day event online. And no, there really aren't short courses in minor injuries.
Hmm.
Um,
Maybe when we start the trauma care virtual learning environment, that ought to be something we look at to putting in there.
What I will say, and
Um,
I meant to put it on a slide, is there is a FOMED site and it's called Don't Forget the Bubbles, which obviously harks back to the play specialists. You saw a picture of mine there. And Don't Forget the Bubbles is a joint Australian UK website with lots of blogs, and they have lots of nice stuff on minor injuries as well. So don't, it's all one word. Don't forget the bubbles. I think it's .com, but you'll find it straight away on a Google. Was this the slide that somebody wanted, do we think? So
yes, I think
leukemia.
that's the one just of causes.
Yeah. Other things, Osgood-Schlatter's disease and Sever's disease, they're not particularly dramatic. They might need crutches for 6 months or so, but generally heal up pretty well as it all settles down. But a Ewing sarcoma around the knee is quite a common childhood tumour. And even Tim and I have a friend who's got a son who had a horrible osteosarcoma. I think he was about 17 when it started and has had an amputation. So leukemias and bone tumors do happen.
Mm.
And here's the other weird and wonderfuls if you wanted to see it
I
again.
guess the message that you were giving there is that it's every child has injured themselves, every small child has fallen over in the last 2 days, and parents have something called effort after meaning, which is they try and attribute why the child is limping. Oh, it must have been the fall that they had yesterday, and that then comes to you as the history. Oh, he limped after a fall yesterday, so you've got to really ask a few questions and not be distracted or make an error because you're just assuming that what the parent says or the connection the parent has made is actually correct.
And
Um,
David, I'm so glad it was picked up quickly because sadly, days matter for leukemia, don't they? And so for someone to pick that up is great.
yeah.
Which nasal
Um,
bodies can be safely left alone? I've just picked up. Um,
yeah, and that coupled with the how do you do the bag valve mask technique with
um,
a
So the nasal bodies all need to be out, basically. The more organic they are, organic material, the more they'll be prone to infection, whereas a bead can stay there for a month or so, not cause a problem. But they need to be out. So the back valve mask, it is the pediatric mask, obviously, goes over the nose and the mouth normally. So what you're going to do is do what the parent should have done, which is over the mouth only, block the nostril that's not got the foreign body, short, sharp puff, and it'll come flying out of the nostril with the foreign body. That makes sense? So you're putting the mask
yeah,
around the mouth,
I think that's
then
great.
short, sharp
I
puff.
think illustrating your point about not being misled by the limping child, we've got at least three people online with personal stories of
Mm.
family or friends who a limping child turned out to have a serious underlying cause. I mean, it's a zebra, but actually it
Mm.
happens, and it's worth really thinking about and just saying, does this really fit?
Yeah.
Does the story really fit what I've got in front of me?
And
Um,
children don't limp for no reason, it. And I think one of the things that surprised me when I first started working with children was how clever parents are at spotting the child who's malingering. The child's making a big fuss, doesn't want to go to school. Parents are good at spotting that. So as soon as you get to 24 hours of consistent limping, it's too hard an act to keep going with. It's a genuine limp, and a genuine limp in a child has got to be got to the bottom of, really.
uh, Mohammed making the really great suggestion that we should have an online course through the Trauma Care website. Definitely thinking of a virtual learning environment through the Trauma Care website. You're obviously reading my mind, and We're going to be going out for calls for volunteers to be helping us with various aspects of the trauma care education and technical support and social media. So look out for that in in the next newsletter.
I see Andrew's
Um,
got a comment in there about QualSafe talks about giving 10 mils of honey every 10 minutes, up to 6 doses en route to hospital for button battery ingestion. Um, yeah, if that's en route to hospital, that's fine because you're still going to get
yeah,
definitive treatment. Yeah, but not
yeah.
instead of, yeah.
Don't delay looking for honey or going to the
No.
local corner store.
Fiona's got a
Um,
good point there. Check the testicle of a limping toddler. So small children do
yeah,
get torsion of the testis, and obviously their way of reacting to that testicular pain might be to stoop and to limp a bit. So the good point there.
yeah. And little boys sometimes very embarrassed to say it's my testicle that's hurting.
Yes. In the
Um,
kissing technique, do you blow or suck it? So it's so here's your foreign body in this side. We're going to obscure the patent side. We're going to seal around the mouth, and it's a short, sharp puff into the mouth, so the air goes into the mouth, up the pharynx, and the only escape is out of that nostril, and therefore it's going to come down that nostril and push it out.
Excellent. I think that's got through all the Questions? Yes, I think that's got through. Unless anybody's got other questions, there's a lot of people saying thank you online. Can I echo that by saying thank you very much indeed for doing this presentation? Although some people online will know that Ffion had her arm twisted a little bit because actually we're married, so she had no escape from giving this presentation. And I'm sure we'll be back to talking about the Spotting the Sick Child video, which I think a lot of people will have seen as part of their training, whatever their background. So thank you very much indeed, Ffion.
You're very welcome. I'm
Tom,
sorry to
could we
cover
have the
so much ground, but there is so much ground when it comes to minor trauma. So sorry it was a bit of a race through.
marvelous Tom? Could we have the closing slides back up? Thank you for coming. If you would like a CPD certificate, there's scan the QR code for a small cost. You can get your CPD certificate. Even better option, of course, is to become a member of Trauma Care. Then you get all of your CPD certificates for free and get the Trauma Journal 4 times a year and get reduced access to the Trauma Care Conference next March. Thank you all very much for being here. Thank you very much to Ffion for giving such an excellent presentation. We've got a really good set of webinars going. We've got a great event next month with Mr. Karim Brohi, sorry, Professor Karim Brohi, one of our top trauma surgeons from the Royal London Trauma Centre, coming to talk to us. We're then having a break for the for the summer in August, and in September we've got Dr. Gareth Davis, who's Chief Medical Officer to the Isle of Man TTs, talking about the first 5 minutes after severe injury, something we don't usually see. Nobody medical usually sees that, but at the TTs, given the medical coverage they have, they see the first 5 minutes, and there's interesting stuff happening in that 5 minutes. So we've got a really good set of webinars coming up for you. Hopefully we'll see you at another of those events. Thank you all very much indeed.